I'm really excited to introduce Dr. Young Kim. Dr. Kim is one of our radiologists here at UMass, and he has a special interest in MRI, and as I mentioned earlier, with people looking at potentially many, many years of surveillance for this problem, a lot of people have asked me, well, what about using MRI? And until recently, I think the most surgical oncologists that I know were not really enthusiastic about it. MRIs are much more challenging to read than CT scans. Surgeons get pretty good at reading CT scans. We're not so great at reading MRIs, and we don't like change very much. So, but there's been a couple of publications looking at the role of MRI for following mucinous tumors specifically. And when I talked to Dr. Kim about possibly doing that, he was excited. He asked me, you know, can I give him a list of all the people that we're following, and he looked at all their CAT scans, and he's more than eager to help with this approach and using MRI, and he's going to speak to us about that today.
Thank you, Dr. Lambert. I'm very honored to be here as a speaker. So I was asked what the role of the MRI when there is an increasing concern for CT radiation. Patient can have appendiceal cancer in the early, like a 20-something. Many the lifelong follow-up CT scan, that can be a problem. So I would like to explain what the pros and cons of the CT scan and MRI in the diagnosis of appendiceal cancer. That is my talk today. So patient appendiceal cancer can be found incidentally, and the most often patient presenting with the right lower quadrant pain, which is very similar to the symptoms and signs of acute appendicitis. And the patient report to the radiology. And so far now, the computed tomography is the first diagnostic imaging choice of modality. Of course, you can do the MRI. So once the patient and the reporting physician decide to the computed tomography, you are asked to NPO for 4 hours for the study, and you will be asked the history of intravenous contrast allergy, and then history of kidney disease, because of use of intravenous contrast can aggravate the underlying renal disease. So this is a very important step before the CT scan. Once you came to the radiology department, you will be asked to have 2 bottles of oral contrast separately, one in the 1 hour before and then immediately before the scanning. And then most of the time, scanning is performed from the above the diaphragm to the pelvis. After that, you will have IV contrast injections, and the CT scan normally done after the 70 seconds after the injection of IV contrast. And then you will see the CT scan like this one. So I don't know whether you can see clearly, but the structures is a bowel containing oral contrast. This is a bowel containing oral contrast, which allowed us to detect diseased appendix in here. And then what you see in here is the aorta and then vessels. It is enhancing because of IV contrast injection, which also allowed us to detect abnormal and normal structures. So CT has been used very nice, reliable, fast, and patient-friendly diagnosis tool in the diagnosis and the follow-up. CT can be used to detect disease, diagnosis, and then staging. Also, CT can be used for treatment response and the detection of recurrence. Here is the tumor, as you can see. So this CT scan shows very, how can I describe it, grotesque, very ugly looking heterogeneous density occupying most of the bowel, which is the combination of mucin and the cancer cells. And then you know the terminology of pseudomyxoma peritonei, and the CT can easily diagnose the extent of the disease. So CT is very reliable study and a very patient-friendly study. But what do we then worry about? And what is the problem? What is talking about? One is the IV contrast, as I explained you. So someone who has kidney problem, IV contrast cannot be used. And then sometimes patient may have a contrast side effect from iodine, from hives and rash and itching, and very rarely patient can have a severe side effect from the IV contrast. And then actually Dr. Rambert asked me to talk about the radiation, which is the most concern nowadays. I'm sorry for this busy slide, but this slide tells us that the difference between how big the radiation dose of CT scan compared to the chest X-ray. If the chest X-ray is 1, the CT abdomen is equivalent to 400 chest X-ray. It's a very large amount of. In other words, you can say the time period for equivalent effective dose for natural background radiation, you need 2.7 years. So which means one CT scan is equivalent to the 2.7 years of natural background exposure to the radiation. So what is the end result? Please do not quote this number, and please do not try to remember this number. This is a very complicated numbers, and most of the study was given based on the longitudinal study of Hiroshima and Nagasaki survival study. And there may be more study from the large group, 1 million or 2 million study with Medicaid, and then they speculated the numbers from that longitudinal study. So depending on how do you interpret the statistics and data, the number can be varied from 800 to 20,000. But the message from this is that there is a risk. There is a certain risk of a cancer death caused by CT study. So let me briefly explain about what does the radiation effect means. This is a little bit scholastic terminology, but there are two types, stochastic and the non-stochastic. Let me explain the non-stochastic first. Non-stochastic effect is threshold effects. You need a certain degree of radiation exposure. And then it is severity dependence on dose. If you get more, you have more effects, which include dermatitis, from erythema to ulceration, and then hair loss and cataract. But this non-stochastic effect is about the radiation therapeutic dose, not a diagnostic dose you took. Compared to this number, you need a 700 CT scan to get the radiation treatment dose. So in the normal circumstances, non-stochastic effect is not the problem in the diagnostic level. What we are concerning about is a stochastic effect, which is there's no threshold, and then there's no dose dependent. Once you expose to the radiation, you have a chance of a cancer. That is a difference between two. So now because of that, and thanks to the recent technological advance, MRI has been emerging as an alternative to the CT scan. So, and then Dr. Switcher said, MRI is better than CT scan in diagnosis of recurrent disease. I honestly don't agree with that. MRI can be used. MRI can provide better information in certain circumstances, not all the time. But look at that. The major difference between the CT and MRI is that CT has radiation, MRI does not have. But the CT scan is very quick and fast. You know, if you just need lying on the CT table for 5 to 10 minutes, However, actual scanning time is only 15 seconds. You just need to hold your breath for 15 seconds, and your scan is done. The other time is a preparation of IV and positioning something. But MRI, you need at least 40 minutes to 1 hour in the MRI table room, which means sometimes it's not comfortable. Some people may not be able to lie on the table for 1 hour. And then you will be asked, hold your breath repeatedly for several times. So there's another contraindication to the MRI is that someone who has claustrophobia cannot scan with the MRI, and the cardiac pacemaker and the metallic implants and clips, those are all contraindicated MRI study. So I don't know whether you can see clearly from the distance. This is a CT scan, this is MRI, it looks similar. When the CT and MRIs are scanned very nicely, as you can see here, you will see very nicely all the layer of the bowel, the bowel layer. And then the same as the MRI, you can see the second bowel wall in here, very nicely, very equivalently nice. MRI, you need the oral contrast as a CT scan, and then you also need a different type of IV contrast. Plus, MRI need some certain type of medication to suppress bowel movement. As I said, CT scan just need 15 seconds, hold your breath. MRI, you need repeated multiple scanning to maximize the efficiency of the MRI. MRI can provide more information than CT. That is true. MRI can be used a functional study, and then I did not put this way, and then but new image techniques such as diffusion-weighted images give more functional biochemical level. So to do so, you need a repeated study, and then to do so, we need to suppress the bowel movements to get a good quality of images. So look at that. This is normal bowel. I don't know whether it is a liver, stomach, large bowel, and a small bowel. And then on the right side slide shows abnormally thickened enhancing bowel. It's very nicely demonstrated in here. However, the patient was given the glucagon to suppress bowel movements. However, you will see the lot of motion artifact from the bowel movements. In this case, it is not possible, not easily possible to detect disease. So I was able to barely define the disease in here, but maybe not easy. Yep. Similar story goes on to the CAT scan. Someone who has, this patient has bilateral hip processes from total hip arthroplasty. It causing significant amount of artifact from the pelvis. Someone who has the pelvic surgery like this one or spine surgery, you will have a similar effects. And these patients cannot be easily diagnosed with a CT scan, and they have to find another. MRI can be a good alternative to this patient group as well. So when you scan the upper level, you will see the very nice, beautiful image of the internal organ very well. So my message is very simple. CT versus MRI is not that simple, so can be judged based on the personal situation, like a kidney disease, allergy, history of surgery, and then you have to make sure that patient can scan for 1 hour in the MRI room if you want to go MRI. And then of course you have to weigh the risk and benefits, and always good to seek opinion from like a specialist like a Dr. Lambert. Okay, this is all my talk. Thank you for your attention.